2023. Welcome to the OHDSI Phenotype Development Evaluation Workgroup meeting. As a reminder to everybody, this is our OKR. We have shared this broadly with the OHDSI community. Our objectives, we have 3 objectives for 2023. Objective number 1, harden phenotype development evaluation framework. Objective number 2, improve collaboration by enabling community-wide participation on the phenotype development evaluation. And objective number 3, promote the usage of the OHDSI Phenotype Library. We have key results that are part of it. The first key result is as a timeline of Q1 2023, which is to enable the community to complete 10 phenotypes via the current phenotype development and evaluation process using activities like Phenotype Phebruary. Through scientific debate, address at least 4 topics of the community interest and drive community consensus. Second quarter 2023. Clarify terminologies and scientific definitions and deliver a document that organizes such ideas by Q2 2023. Integrate probabilistic phenotyping into OHDSI Phenotype Library, Q3 2023. 2 scientific papers on phenotype development evaluation, Q4 2023. For OKR number 2, we have Phenotype February has 10 phenotypes, so that's the part of OKR 1. Promote clinically trained scientists by having at least 10 new clinician collaborators actively engaged. Yes, somebody speak something?
That's me. I think we have to. So the 11th phenotype is already. So I think we have to give credit for the 11th phenotype.
Yep. All I'm reading is the OKRs. We can do more than the OKRs. This was something that just a reminder to the group about the purpose of this group.
Got it.
Yeah, the promote the usage of the OHDSI Phenotype Library. So complete peer review of 10 Phenotype February definitions and 10 additional phenotypes by Q4 2023. So obviously Maxim's work is contributing to the 11th, 12th, 13th, 14th, 15th, and 20th. Formalize the submission process and perform at least 2 communication sessions on the OHDSI Phenotype Library. Execute at least 2 OHDSI studies that uses core diagnostics in the OHDSI Phenotype Library to generate characterization evidence. Write a scientific paper on the OHDSI Phenotype Library. So this is our OKR for 2023. The agenda for today, the proposed agenda for today is Anna. She's going to talk about the vocabulary landscape. She asked 10 minutes of time of the work group. Aza Shaibi and I will try to talk about the Phenotype February and what do we need to make things to completion. If Dr. Mirza Khan is available, we'd like to talk about myocardial infarction. And Juan, if you're available, would like to talk about your progress on probabilistic phenotyping. Is there any other agenda item that the group would like to talk about?
I thought Gautam, we can also, maybe that's part of the Phenotype February, but we're gonna discuss the publication plan, correct?
Yes, that's a good one. Okay. All right, so I'm going to add that to the agenda. All right, so Anna, are you on the call?
Yep, I am.
Before Anna goes, do you want to check if there's any newcomers? Anybody would like to introduce themselves if anybody's new or their first time on the call?
Yeah, that's something. Yes. Is anybody new on the call who's never attended this work group or has attended the work group but have never had an opportunity to introduce themselves? Okay, not hearing any, so we'll thank you everybody for coming back to the phenotype work group. Anna, the floor is yours.
Thanks. Well, that's really not a formal presentation. What I wanted to get is a sort of to see if there is something that you haven't covered in the survey that hopefully everybody filled for the landscape assessment, and hear from you if you guys have anything to share in terms of how you use vocabularies for phenotyping. Are there any tricks of the trade? Are there any specific things that you do that you would want to share? Is there something you want to bring up in terms of how something doesn't work? Stuff like this. And I'm sure some of the things are regarding creating concept sets and stuff is already covered in the survey, but I wanted to basically see if there's anything else anybody wants to share or discuss.
Does anybody in the
And
workgroup
I'll
use-
throw. Oh, go ahead.
Go ahead,
Yeah.
Evan. Go ahead, Evan. I was throwing
Well,
an idea, provocative idea.
I think there are, and I think a couple of these things have been represented. I think one area of uncertainty, and I'm kind of running into it right now with HIE, is mapping between SNOMED concepts and ICD, ICD-10 in particular. And I don't. Part of it might just be user error, where I'm not picking out, where that relationship is, and seeing the kind of ICD-10 standard concept and being confident that I'm getting its children. But I think there's some mapping issues that surface there. And then I'd meant to get to that survey this week. I just didn't get a chance to. But the other area which I know you know well, having been involved when we were making some of those surgical concept sets, is kind of challenges within the procedural domain and mapping there.
Sure, yeah. Procedures are painful. Absolutely.
Yes, I don't think it's anything kind of new that I'd be raising there.
Well, is there is there something? Well, yes, I remember that we had this struggle with procedures and surgeries. But have you started doing anything specific with procedures recently? Like,
So no, I mean, it's something, and part of my hesitance was that I couldn't kind of further specify the problem just due to memory attrition. But that is something that is kind of on my radar in the next couple of months, in particular with revisiting that major surgery cohort. My recollection is that there were challenges. It's certainly kind of challenges in mapping between CPT and the procedural domain of ICD-10.
yeah, there is no hierarchy. Yeah, absolutely.
Yeah. And then, as things kind of come to me, I'll certainly kind of feed them back, because I'm going to be revisiting that work to try to wrap it up.
Yeah, the problem exists, unfortunately, and every time I try to create procedural concepts, they're so bad every time.
Yeah, Anna, so were you aware of this ICD-10 to SNOMED mapping that Evan brought up, or is that new information?
I mean, from time to time, people report errors with the mappings, right? And the GitHub is the perfect place to put the bug reports about the mappings. And usually that gets fixed rather quickly. But of course, because all of the mappings from ICD-10 to SNOMED were created internally in the OHDSI, the errors do exist. So GitHub is very helpful in this way of bringing awareness about potential issues.
I'll profess a little bit of ignorance there. The GitHub project that we should go to is that just a presumably a vocabulary. Okay. OHDSI Vocabulary, is that kind of the
Vocabulary version 5, which
Okay.
may not necessarily be the best name for the repo.
Nope, no worries. Good to know. Thanks.
What were you finding there, Evan, for that one, for HIE? Was it that it was unmapped, or was mapped to stuff that seemed inappropriate?
No, I think it was unmapped. Like there's an HIE standard concept that I believe is from SNOMED, but when I was looking into the included codes, I couldn't find any ICD-10 there. And when I went back and I can search, and so I've added them in as non-standard concepts to make sure that we catch them, but I couldn't verify that they were being brought in through grabbing the standard vocabulary parent.
So what non-standard concepts did you bring in?
So interestingly, I brought in I think ICD-10, and I think because some of them were kind of country-based modifications, I brought those in because I wasn't sure if I don't see the ICD-10 there as a standard concept, I didn't know if I could trust that it's going to bring in the variants that come from different modifications.
Right, but if you don't see the ICD-10 CM there, then you're not going to get any of the US. It's not going to map to any of the US data.
That's right. Yeah.
Unless it's some oddball thing that happens to use SNOMED in the coding, but that's pretty rare, I think.
Yeah.
All right, I've seen another hand raised. David, you're next. Yeah, you're muted, David.
Thank you, Otto. And thank you, Anna, for bringing this topic. My question is with regards to the measurement table and whether there's going to be any intention to standardize this across data in this next iteration. And then the other comment is also related. I've heard, I'm not an expert at all in healthcare resource utilization, but I heard that there are some issues when it comes to mapping certain healthcare resource utilization related tables, I would say, but not sure if there's anything around that that's also being considered. So the thing is that apparently there's some issues when adjudicating from certain databases, adjudicating the correct visits to the OMOP tables. But I'm not sure of this one. I mean, I just wanted to hear from you if this is something that it's being discussed or not. Just I was attending a conversation around this, and apparently there were some issues with regards to this.
I mean, the healthcare utilization, and Gotham well knows because he was doing a lot of work in that realm previously. It's partially the availability of the data and mapping it to OMOP CDM, not only vocabularies. So we did get a couple of mentions of it in the survey, but for now the scope of what is needed on the vocabulary side is not really clear. Like there is some needs in terms of the OMOP CDM and how it accustoms some of the data about payers and stuff, but less so in terms of the vocabulary content. But I do feel that we are getting more people who are interested in this type of research in the Odyssey over time. And with the procedures, yeah, that's a good question. We did have an effort that spent, I think, 2 years that tried to harmonize all of the procedures together. And some ICD-10, PCS, and CPT-4 were linked, so parts of the hierarchy were linked, but not everything. And it does seem like it's a huge research project, in fact. So the response of whether it's going to be done anytime soon, I don't think so, because it does seem like a huge project that actually would be nice to collaborate on with the broader community, because we do have some vocabulary experts, non-Odyssey ontologists, and it would be nice to get their inputs on it. But we do hope to solve it one day, either in terms of creating the concept sets so through Phoebe or something, or on the vocabulary side, because it is a pain every time.
And on the measurement table, Anna, I want to bring to your notice that we struggle with measurement type concept IDs and the measurement value sets. So like just to specify if a lab result is positive or not having a vocabulary to help us means that we have to search for every
exactly
every concept that represents the idea of positive, which could include things like true, more than one, one, and so on. So having the power of the vocabulary grouping and ancestor would be fantastic for that space, I think.
Didn't Patrick try to characterize somehow what's in the data for for the units and stuff. Yeah, I know the problem exists. Also, everybody does it in the ATL, however, they want to do that. So do you know if there was any movement in Jensen in terms of creating this value sets for the units?
There has been an attempt to calculate the frequencies of these units in the data that we have access. And there has been some attempts to use that as insights to inform some of the phenotyping. So example, the neutropenia work was informed by it. And that's about it. We don't have a recommendation to the vocabulary work group on how to use those insights into a general solution using the vocabulary hierarchy.
That would be really nice here. I mean, it does seem like a very powerful resource that can be used, right, in this realm to adjust the mappings.
Yeah,
I'm putting it down into my notes as well.
Yeah, I'm gonna call somebody here. Ben Hamlin, do you have any insights from NCQA work about units for lab results? I see you're on the call.
I mean, I know we have very specific guidelines around lab submissions for unit reporting, but I don't know if they would be terribly useful. I can look them up for you and try and get them to you, but I can't recall them off the top of my head. Okay. It's too much in the weeds for me, and I go dig around and see what I can find for you in the guidelines.
Apologies for putting you on the spot there. Aza, you have your hands up, and we are almost on about time for this particular topic.
Yeah, so I actually I wanted to bring up 3 things which you guys already brought. I think overall, from a phenotyping perspective, in like working on this for 2 years, working with the vocabulary, I think when it comes to condition, the mapping is pretty, I would say, robust in terms and like sufficient for what we do. Per se, and I can say more about the US with ICD-10 and SNOMED when it comes to condition. And occasionally, few things shows up in terms of like maybe not the most appropriate mapping. And I think GitHub provide a great way to fix these problems very fast and move on. So I would say that in terms of conditions, we are really in a good place vocabulary wise, but again, focus more on the US source vocabularies and standard. But the biggest gap from phenotyping perspective is the procedures and measurements. And I understand that the mapping is very, it needs a big effort to get the procedures to have a hierarchy and a more standardized way to do it, similar to condition. Totally understand. But Anna, I was actually thinking, as we figure out how to get those, both the measurements in terms of unit and the procedures correctly done, is there a way that we could help people understand how, with the current status of the vocabulary in those domains, what a phenotyper need to do to make sure that they're doing a good job covering procedures? So I learned this by practice, and I still can't nail it down to say like, okay, if you want to build a procedure, you really need to make sure that you look at CPT, you look at SNOMED, you look at MOINC. Like it's so not like all the other like ICD-10 approach. Like I haven't done it multiple times. I still think when I do it, it's more of a, okay, let me just pick everything. And I actually don't know if this maps to this or if this included this. And it's more of a trial and error every time. And I wonder if somebody who's more familiar with the current status of the vocabulary in procedures and then units and measurement can provide a more standardized steps for phenotypers to follow to make sure that they cover their concept that they need. And unless like that with procedure, you can learn it a little bit. With measurements, it's even harder. And we're doing what you were saying about like use that table that provides all the unit and their distribution, and that can help you. But even that work, can we nail this down into steps for people to follow, so they know how to create phenotypes that are based on measurements or procedures. Until we have this world of where vocabulary mapping can be done as intuitive as the condition situation.
Yeah, that's a perfect point. Having more educational materials that are really targeted to how to do something would be really, really good. I agree. This is something that definitely should be done in the near future. And then it would be a further discussion would be where to put it and how to effectively distribute it, but that's a separate conversation. I totally agree. No, it would be very useful. Thanks, Asa.
Yeah, and Gautam, I just looked up the lab question. We have a ton of information on date specificity, but nothing on unit specificity. So sorry. I can ask Wendy and see if the auditors have something that they use, but nothing in our general guidelines. It's pages on the dates, but nothing on the units.
Oh, that's fantastic insight, Ben, because from my understanding, NCQA has made tremendous progress on providing guidance on auditable ways to phenotype, essentially. And that guidance not having units is an insight. That means that's an opportunity for us to make progress there.
Yep, I agree.
So it is a gap. Any other conversations on this topic before we move to the next one? And are you satisfied with the discussion?
Yeah. Thanks so much for your time. Yeah, that's very helpful.
We're going to go to the next one. Asa and I would like to go over Phenotype February. What do we need to make progress? Specifically, as you all know, for Phenotype February the goals of Phenotype February was to get 10 phenotypes to done. Done was defined as completed peer reviews and in the phenotype library. We are right now have some that have been accepted into the phenotype library. So let's go through them really quick. I have a spreadsheet document that we are maintaining. As you probably recall, I can find my mouse pointer. Okay, there you go. That's not it. Close this document. Cool. Definitive February. So this document, all of you have access to. This document was collectively built by this work group in, I think, one of the last meetings earlier this month. This is the publication plan for the 10 phenotypes. So just to recap very quickly, we have 10 phenotypes, and there are 4 phenotypes in the first week, 3 phenotypes in the second week, 2 phenotypes in the third week, and 1 phenotype in the fourth week. All of these 10 phenotypes have progressed. The various 10 phenotypes in this spreadsheet are the ones that are labeled P1 to P10, that is acute pancreatitis being the first one, all the way till the P10, which is hypoxic-ischemic encephalopathy. All of these phenotypes needs to be in the phenotype library for it to be considered a success or complete. What we also have is a stretch goal, which is the publication plan. So on the column number C are the publication leads for these applied ideas as of right now. And it can change depending upon where they are. So some of them are proposed. So on the third column are some of the revised and submit. So so in terms of the current status, and specifically talking about complete and into the OHDSI phenotype library, acute pancreatitis is not yet complete. Anaphylaxis is not complete, but it was actually rejected. Appendicitis is complete and accept. Acquired neutropenia is accept. Systemic lupus erythematosus is accept. Acute hepatic failure is incomplete. Adult dermatomyositis is ongoing. Parkinson's disease is ongoing. ST elevated myocardial infarction is ongoing. And hypoxic-Ischemic encephalopathy among neonates is ongoing.
And Gautam, maybe to be specific about the ongoing one, So some of them, some of them are in the peer review status and some of them in the evaluation status, correct?
Correct.
So,
Mhm.
yeah. So I just, okay, or maybe we can go one by one to
Yeah.
see which is, okay.
So let's focus on Phenotype February specific conversation. Let us not focus on the publication plan as of right now. That's okay. We should focus on the publication plan also. So in terms of acute pancreatitis, I was for the first 4 phenotypes, I was obviously the submitter, but when I submitted the content, but there were different peer reviewers. For acute pancreatitis, Evan was the peer reviewer, and Evan has asked for 2 elements before considering to accept it. So so in terms of the 2 action items that are pending is his requested submission of fee evaluator output, and is also requested submission of the comparison of characteristics of persons who had acute pancreatitis and were managed in an emergency room setting versus the acute pancreatitis who were managed in acute care settings, which is inpatient or ER settings. The motivation there was he wanted to see if there was evidence of specificity errors by persons who are in the ER for suspected acute pancreatitis, but then were ruled out, and the decision was made that they do not need admission. And so they did not have acute pancreatitis according to the judgment of the clinician. If we are calling those individuals as having acute pancreatitis, we may be introducing specificity errors. So that's one pending. Evan, is that a fair summary?
Yeah, and I think in particular with that cohort of ED only, I mean, if you kind of take a look at a prior based on some literature, we expect 80% of these people to be admitted. And so, the challenge is that it's really hard to distinguish in the observational record between just a simple rule out process or, a diagnostic closure. And so one additional modification that I'll kind of suggest is that maybe we require a bit more evidence in those ones that go to the ED and don't get admitted, for instance, with a second diagnostic code, within 30 days, that kind of something that kind of just that shows that there's something in the trajectory that suggests they have more than just a rule out process. And so that's something I'll look to configure.
Got it. But as a first step, let's just create that cohort and see how different they are from the people in the hospital admitted. And then if we see differences, we can take an action of adding an additional qualifier, like a second diagnosis or something like that.
Yeah, my presumption is that they're going to be different just because of the information density in the health record if they're not admitted. Like things, I presume they'll look different, but I think it's fair. I'm happy to prove that out too. Yeah.
Okay, so you're creating that additional cohort, and Joel is already running fee evaluator for that. So those 2 items should complete this work. And in all cases, but Evan, following the framework of Patrick, you still would accept that phenotype, correct?
Yeah, I mean, we want to have I'd be comfortable with it, just with that knowledge that we might have a specificity issue within that segment of the cohort.
Yeah, we'll update the error discussion about those particular people. Let's first quantify what's the proportion of those, and that you will get that once you create that cohort, because the overlap will tell you what's the proportion of those in the current cohort. And then that would give us a magnitude of the potential specificity error, meaning that if all of them are false cases, then that gives you an idea of how bad is the specificity error could be. So if we find them to be only 5% or 10%, then we can put that number in there. And then if it's huge, it probably needs further investigation, like the comparison you would be running. Of course, fee evaluator will also give us an estimate of the measurement error. So I think these two steps together will give us a more idea of the measurement error, and would go with the documentation of this phenotype.
Sounds good.
Okay. I purposefully hid the columns that represents the publication plan. We'll use the same document to track both the publication plan and the Phenotype February activities. Jamie Weaver is the lead on the publication plan, but we'll address that at a future time. Anaphylaxis. So the anaphylaxis again was submitted by me. Andrea Noel was the reviewer. Based on the review of the initial based on the review of Andrea Noel, she suggested that this cohort has specificity errors. A subgroup of us worked to evaluate if that assumption or no, the hunch of Andrea Noel was accurate. It turned out it is accurate, and so we have decided that to essentially withdraw the submission and continue to work on it and reiterate on the definitions. So this particular submission from a Phenotype February process has completed its life cycle. It needs more work. It needs more work. This is an important phenotype, so we'll continue to work on it as a group. That new work will be led by Dr. Andrea Noel. She has identified a few other experts who will also work with the OHDSI community. But she's currently on vacation. So once she comes back from vacation, she will lead the creation of a plan for this phenotype. The next one is appendicitis. Asa, you are the peer reviewer for it, and you had.
Yeah, that finished its life cycle. It's accepted to the library, and it's in terms of Phenotype February, it reached its final destination. So accepted. The document, we already updated the documentation to take into consideration the revisions from the peer review process. And then the only thing is that we're updating. Today I'm gonna add to the post our fee evaluator results. Right, appendicitis is the one that yeah, we had the results from the past, but we all okay. And Joel said he would run another run. We have results from the past.
Yeah, I completed the new run of it.
Okay, perfect. So once Joel send it, he can post it. So we'll just post the fee evaluator results to be in there. And that's a good case where we have results from the from chart reviews, so we can compare from prior work chart reviews, so we can look at how much the numbers are in agreement. But yeah, so this completely reached its, in terms of Phenotype February, reach its destination, have all the documentation associated with it, and ready to be in the library. The publication part is going to be led by Evan, so that's a separate discussion. But library is done, documentation is done, and then we can just upload the fee evaluated results.
Right. So just for everybody's awareness, what I'm doing right now is actually pushing the accepted definition live to the Phenotype library. The way I'm doing this, I have an R package in the background that reads it's a dedicated Atlas instance that is meant only for the OHDSI Phenotype librarian. So I'm the librarian right now. I have my credentials with write access. In that Atlas instance, I'm using this text box of Atlas to document the decisions that were made. So as you saw me change the status to accepted. I put the peer reviewer as Aziz Shoaibi. I put the contributor as my name. I have referenced the OHDSI forum thread that has the discussions, including the recordings and so on. And finally, this is the indicator that the R package uses. A prefix of P essentially shows pending peer review. But if I remove this, this is now considered accepted to the OHDSI Phenotype library. And it is now accepted. The R package will go through its life cycle. So the next run, I'll probably do it in a few weeks. I just have to press a few buttons. It uses the various packages in this script to run and create the GitHub R package, which will have a library entry of record number 234. This is now considered accepted. Okay, so now let's go back to the spreadsheet. Acquired neutropenia.
Anna accepted that as well, as is. That's the one that we have pre-evaluated run recent. I just need to upload it to the forum. I sent it to Anna and she used it in her peer review, but it's not in the public. So I will add it to the post. So it's as part of the evaluation material. But Anna accepted it as is and already raised, added to the documentation of the possible measurement error. And so that also completed its life cycle.
213 and 214 were the ones that were accepted. So I'm going to go change this, do the same thing. 213.
No, I think it's the acquired, right? She mainly accepted the acquired neutropenia.
The 213 is the acquired neutropenia or unspecified leukopenia. 214
is the isolated. Yeah, okay. The isolated discussion, I think Anna said that it's not very clear the difference in the clinical description, but that's a documentation.
Anna, do you recommend any? Are you okay with accepting both 213, 214, or just 213? Okay, she might have dropped off.
No, she's there. She's on mute.
Okay, she may have dropped.
Or maybe she's dropped off.
Okay, all right. So Aza, what do you think what do you interpret? Did she accept both or just one? Or should we just accept one right now and wait for her to?
Yes, we can go back. She definitely accepted the not the isolated one, the acquired neutropenia, and most of her comments was on the isolated. The regular, the one without the whole thing about the isolated. The isolated one, we'll just go back on it. She just said.
We'll wait for clarification on this one. We'll accept this one. Got it.
Yeah.
All right. So the acquired neutropenia or unspecified leukopenia with the ID 213 is currently accepted. All right. So let's go to the next one. Systemic lupus erythematosus. I believe I've accepted this, and that announcement was made in the forums. Joel?
Yep.
And congratulations, Joel, again, for making this into publication. So we only have to do 9 publications. Acute hepatic failure. Acute hepatic failure is currently incomplete. There was a new interest by another OHDSI collaborator to push it forward. We're working actively on it.
But Gautam, it's still stuck in the evaluation. We're still waiting for an evaluation. So to be more specific, where it is currently, we still awaiting evaluation. Just to be specific of what's the status for us, because you want to document that. And I think now there's a plan to do a open call evaluation. So we have multiple collaborators do the evaluation.
Yeah, so there is a proposal. So let me share some perspectives. So this particular phenotype, Dr. Christian Reich was the evaluator, and Patrick Ryan was the peer reviewer. This is a very complex phenotype that requires a lot of effort to make progress on. Dr. Reich has a few more days to complete the evaluation, and if he does that, then Patrick Ryan will be the peer reviewer, and then a decision may happen. We can, as a work group, offer up assistance to perform the evaluation, and we're currently waiting to see what the next steps are. So we have offered up a collaborative evaluation. Anything else on this phenotype? Okay. Next one is adult dermatomyositis. Is Dr. McCauley on the call? Do I see him? Okay. Okay. So my understanding about the status of this phenotype is they're feeling good about the sensitive phenotype and would like to submit that for peer review. Just waiting for an official confirmation. We have a I will reach out to Dr. McCauley this afternoon to see where they are. They wanted to take the sensitive definition and compare to some of the implementations of OMAP inside Johnson & Johnson, not Johnson, that's where we work, John Hopkins University. They sound similar. So once we hear from them, we'll ask that they're good with their evaluation. We will ask the peer reviewer, which is Asia Golazar, and then we can see if we can make progress within the end of the month.
Yeah. So we basically, for one variant, I don't know what they want to do, but for one cohort, because they started with multiple cohorts, but for one cohort, which is called the sensitive cohort, it's been evaluated as part of the group discussion. So we have evaluated it. We haven't written it up yet, so we need to write it up. And then it's still pending fee evaluator and Joel and Dr. McCauley are working together to get fee evaluator. So that is a sensitive. So if we just narrow it to the sensitive cohort, that needs the evaluation to be written up. And today we'll discuss, Gautam, how we're going to do this. How we're going to support them to do this. And then we need fee evaluator results. That would be enough to submit for a peer review just on the sensitive cohort. If they want to do something more specific, they can, but we can move forward the sensitive because it seems like they're satisfied with it.
Yeah, so I have completed the p-evaluator results for it from the Janssen databases. Now, just a quick question on that. So he said he was thinking about running p-evaluator on his data.
Yeah,
but his data is a registry, right?
No, CHR, they have a registry as well. So
they have registry. That's what they're using, but they have an EHR with people. Okay, because I need negatives in there too. That's why I can't use a registry.
Yeah, the registry will be another gold standard. So we will have two gold standards: the probabilistic model and
Next phenotype is a Parkinson's disease phenotype. Dr. Alan Wu has made a lot of progress on this. Asa, you had a conversation with him recently.
Yeah, so we're in a very similar status that we want. So again, he's proposing two different cohorts. For one of them, the unity cohort, that has two variants, but let's think of it as one cohort. So the unity implementation is the cohort have been developed and evaluated, and he's also happy and actually written up because I wrote the evaluation. So we have finished the evaluation for one, and then based on that evaluation, he did some iteration on it, and he was finalizing that iteration. And then on that, he's running with Joel again, fee evaluator. So that should make the unity cohort ready for peer review once they finish the fee evaluator results.
Yeah, I've completed it from our side.
Yes, I think if you give Joel anything, he'll complete. It's like amazing, Joel. But Gautam, we don't have a peer reviewer.
Yeah, so any volunteers to be the peer reviewer for Dr. Wu's work?
That's Parkinsonism.
We're looking for a peer reviewer from the community.
I'm happy to do it if there's no other takers, but happy to
Oh,
step aside and let somebody
please.
else. Oh, great.
Oh, we got one.
Okay.
Hey, Galton.
Perfect.
Hey,
Fabricio.
I'll mark you as the peer review.
Yes, I volunteer.
Fabricio, you're a neurologist, or you work in neuroscience?
No, and that, by the way, I was wondering about that. Do you need what credentials? Because I am not a neurologist.
Yeah,
We don't need credentials.
No, we don't. So just to as of right now, the peer reviewer's responsibility is summarized as to see if it is really, really bad. And if it's only if you think it's really, really bad, then you recommend it to be not accepted. And that's it. That's the guiding principle for a peer reviewer.
I see.
That's
so
overall, but consistently, the reason why we say we don't need to be like, it definitely helps if you have a clinical background, but the idea of the peer reviewer is to review the material submitted by the submitter and the evaluation, and just and including the data, so including things like Phe-evaluated and the observations from cohort diagnostics. And based on that, Dr. Wu in his write-up are making conclusions. And the peer reviewer role is to look at this data again and see if he or she agrees with the final conclusions or inferences on measurement error that the submitter is making. It definitely helps if you have a background, clinical background, because you can also add that clinical insight, just like what Andrea did when she was doing anaphylaxis. However, it's not necessary. It's just you look at the data, and as a scientist, do you agree with the final conclusions that the submitter is making?
Andrea asked the question about Parkinsonism. I think it does include Parkinsonism, but not secondary Parkinsonism.
That's right. Yes, so it is Parkinson and Parkinsonism disease, but it's the other word he's using is the idiopathic, right? So he's not including secondary Parkinsonism or Parkinsonism. So not drug induced.
Yeah. All right. So I'm going to continue the next one. Sorry, we have 10 more minutes. So ST segment elevation, ST elevated myocardial infarction. I don't see Dr. Khan on the call. So they have made good progress here. They have developed phenotypes. The data partners from IQVIA helped Dr. Khan execute cohort diagnostics on 2 data sources. Yesterday evening, I received the output of cohort diagnostics, which I have now posted on data.odyssey.org. So if you go on data.odyssey.org and search for ST elevation myocardial infarction, you should be able to find their output. They have done a post on the initial review, and try to reach out to Dr. Khan and others to see if they need further assistance before they are ready for the peer review.
But they have a peer review.
Sorry.
Just one comment. They have a peer reviewer already that looked at it, correct, Gautam? I've not spoken to the person, so I don't know his name properly, so I may be saying his name wrong, but I believe his name is Adam Atif, and he was the assigned peer reviewer, but they work collaboratively. Dr. Mirza Khan and Adam Atif worked collaboratively. Correct. So they're good on their own. Okay, so we'll just follow up with them. But
another volunteer peer reviewer, I believe, who also stepped up.
Yeah, I mean, just as a matter of practice, probably better to have an independent peer reviewer if they work together.
Yeah. So we want to keep the peer reviewer independent, and so in this particular case, Adam Atif and Mirza Khan did work together, which is fine. So that's why we have a third reviewer who has also stepped up.
Okay, so we'll talk to them today and see if how we can loop in an independent reviewer. But my understanding is they're on the same bucket, that they looked at multiple cohort definition and they're good with one of them, but they're still trying to iterate on the others.
Yeah, that does we'll learn more.
How about Phe evaluator? Joel, you're already working with it, right?
Yeah, so this is probably not going to be a short-term thing. It's an interesting methods question for Phe evaluator to be able to separate out the different myocardial infarctions, STEMI versus non-STEMI. One question I had for you, Gautam, are you promoting exclusions criteria? I mean, because that, when I look for Phe evaluator, one of the things I look for is to be able to put in exclusions as and as far as the, is because especially from
Yes,
for
so
STEMI.
I'm sorry to interrupt you. I'm sorry to apologize. We've got 7 minutes. Yes, I'll quickly answer your question. Yes, I think we have, the exclusion and improving the specificity of the definitions using exclusion rules is something that we have to continue to think about. But for Phenotype February, we have made a deliberate choice of not introducing new ideas. So this will continue on the old ideas, but we have to talk about those new ideas soon, probably in the next call.
Yeah.
Sorry, apologies for interrupting.
Yeah.
Hypoxic-Ischemic encephalopathy among neonates. Evan?
Yeah, so in progress, kind of completing a mind meld between what I've been doing and what the group at Hawkins has been doing, and we'll have some candidates today. So we'll need to kind of evaluate the candidates and some components of the candidates in cohort diagnostics, and then it would need review. So I don't know exactly how to do the reviewer, because again, we're working collaboratively, so probably should be somebody else.
So we need a reviewer.
Hold on, the evaluation is, you can do it together, the evaluation. The peer review needs to be independent.
Yes. Yep.
Okay. And so you're in the development phase, right? You still
Yes.
don't have cohorts. Okay, so they're still in development cohort phase.
Yeah.
Okay, and I see somebody raise their hand or something. Did I miss something?
Yeah, interesting. Yeah, I did a quick look through of counts for possible XSpec for HIE, and it looks pretty small. I might be able to do one or two databases. I'll give it a shot, but we'll see.
Okay, let us iterate a little bit before you spend time on there.
Okay, that's right, because you have more codes that you might be introducing.
Yeah, that's right.
You also might have an issue of mapping. Okay.
Yep.
Gautam, there is another dimension, which is for those last 4, the developers are running them on their own databases, and we're providing help from the once you run them from the J&J data sources. But we talked about having other data partners also run, so they can be part of the evaluation. So let's make sure that we help getting resources. I know some people already at the beginning of the month volunteered to run. So let's coordinate that work.
Yeah.
Especially for the last 4.
Yeah. All right, so we got 4 more minutes. Juan, if you're on the call, I'm going to skip Dr. Mirzakan's because we already talked about it. Juan, if you have on the call, can you talk about your progress on probabilistic phenotyping and the ideas we discussed before?
Sure. Hey, I'll try to do it in 4 minutes because I have another call. Yeah, can I share the screen or is it blocked?
Yes.
Okay. My team decided to make my computer super slow today. Okay, there we go. Can you see that?
Yes.
Okay, yeah. So what we wanted, what I mentioned last time during the Odyssey call seemed a little big picture, big level, but it wasn't too narrow. But this is basically what I was trying to discuss there with probabilistic phenotyping ways. That, we have 3 different ways, as I see it, that we can use it for the probabilistic efforts of this group in the community. One is, to use Aphrodite as intended. You specify your keywords, you let the software find cases and controls and build models and refine. So that's, what's on the papers that you can find published. The other thing that I mentioned more during the last community call was, to use this Aphrodite to help atlas definitions. We feed an atlas cohort, we build models, we look at features, and then we iterate the atlas definition. So that's what Tiffany, Kalkan, and I tried last year's Phenotype February, which, resulted in interesting discussion, something that we're still writing up to publish. But yeah, so that's, marrying the two. One way is doing it completely independent. And the third one is turning this atlas cohorts into probabilistic phenotypes, which, it's a little bit of a different idea. I mean, it's kind of based on, the functionality needed for number 2, but, it has a very interesting perspective in the sense that, okay, you take this rigid definition to find, what hopefully high precision, patients with the phenotype, Okay, fine. You can only take, it's binary, but you turn it into a model, right? So you turn that cohort into a model. Now you can actually rerun it on the rest of your patient set and pick out those, and hopefully, potentially, this is not fully tested yet. If we can pick up those extra people that are not 100% phenotype, but 80%, 75%, or any different level of percentage. So that's the other way that I was talking about. Pros and cons, right? So here, with Aphrodite, this is, I think, one of the reasons that a lot of people don't use it, is that you can't really have a very rigid definition. Well, that's the pro, but it's also the con for some people, right? That the definition is too relaxed. You don't have the structure of this lab. You don't have temporality, so that's one of the biggest drawbacks. But the pros is that you don't need this rigid. You don't have you don't have a rigid definition. You can use node NLP, and you can let the selected patients actually be the definition. The second approach of using Aphrodite to help Atlas definitions is that the cons is that you need a definition, so it doesn't help when you can't build a definition. People that miss an atlas might continue to be missed. This is something that we haven't evaluated, but that's kind of the theory behind the third option. And the process that you do take advantage of this rigid definition, and you can rerun it to kind of see what you missed, which might happen or not. The last type of approach is when you turn this atlas models into probabilistic ones. And this is, this is different than the second one in the sense that here you just want to use the model out of those patients. You don't want to, tweak the atlas definition. The con here is that, probabilistic model will have the same limitations as the atlas definition, most likely. And, but the pro is that, it's a quick way of removing that rigidity of the atlas definition. So, this is mostly the stuff that I wanted to talk about, and have people think about it, because we should discuss, right, how we want to bake something into the definitions to put definitions into the library, or if we just want to treat it as completely separate thing, and not and leave it as it's been in the last couple of years, where this is just a different way rather than a way to either to help atlas cohort definitions or turn them probabilistic. And with that, I think that, I'm around time, but I would like to hear what people or anybody has to say, or we can discuss it next meeting.
I'd like to propose we go ahead. Sorry.
Oh, I was going to say I'd love to dig more into this and discuss next meeting.
Totally
there's a lot here that that is, I think, exciting, and that we would really benefit from a broader discussion with more time.
4 minutes does not give this justice.
No.
I think we should lead off next meeting with this.
Yes. So, okay, I'll put that as the agenda for the next meeting. I also have some ideas on creating a subgroup focused on this one item, which we'll use as an asynchronous communication. So thank you everybody for attending the OHDSI Phenotype Development Evaluation Workgroup 4th Friday meeting on February 24th. Looking forward to continue the collaborations next month and building on the learnings of Phenotype February.
And it's a good lead in. There's the discussion topic for this week's debate, right, on this issue. So it's actually a good teaser, and so we should continue it there in the meantime.
Yeah.
Sounds good.
All right. Thanks, Juan.
Thanks. Have a good one.
Jacob.
Right.
Gautam, Jacob, if you can stay on the call, because we didn't talk to Jacob about his paper.
Yeah, so let's hold on.
Yep.
Let's stop the recording.
Yeah.